Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show hosts or the guests are their own. Enjoy the show. Welcome to MS&Me Interviews. I am your host, Erica Lyons Richardson. This week we will begin our series focusing on some of the research and MS treatment innovation presented at ECTRIMS 2018. It was held in Berlin October 10th through the 12th. For a quarter of a century, ECTRIMS has served as Europe and the world's largest professional organization dedicated to the understanding and treatment of multiple sclerosis. The European Committee for the Treatment and Research in Multiple Sclerosis, ECTRIMS, is a non-profit organization and an independent representative Europe-wide organization devoted to MS. ECTRIMS works with researchers and clinicians of its member countries and with other organizations that share similar missions and objectives on a worldwide scale, creating a networking and collaboration opportunities. The ultimate goal of ECTRIMS is to improve basic and clinical research and clinical outcomes in MS. For those who are in the U.S., there's a sister conference, ECTRIMS, for which MS&Me Media was pressed earlier this year. That was a wonderful event in February and March. In interest of keeping our show patient-friendly, I will do a short summary of some of the top MS research presented at ECTRIMS. 3 days of mounds of science compressed into an easy-to-understand review from a patient perspective, patient-friendly language. So let's get started. Our first topic is use of disease-modifying therapies for multiple sclerosis. It has no ill effect on pregnancy outcomes. Disease-modifying therapies do not affect the fertility or pregnancy outcomes for female patients with relapsing remitting MS, according to the research presented at ECTRIMS. Researchers evaluated whether the decision to receive disease-modifying therapies for MS should be influenced by the patient's intention to become pregnant in the near future. Data obtained from patients with relapsing remitting MS who had given birth between 2002 and 2017. It was analyzed to determine the effect of the disease-modifying therapies on the disease progression, their fertility, and pregnancy outcomes. A multivariate analysis was performed and adjusted to disease severity, age, previous pregnancies, and known fertility problems. Now, this was when they were taking the meds just prior to becoming pregnant and not during pregnancy. Consult your neurologist right away if you become pregnant, so any changes that need to be made to your medication can be adjusted. Now, our next topic is infections. Severe disability complications are more likely causes of death in MS patients. Infections and complications from severe disability are the greatest contributors to mortality among MS patients, according to this new study, a population-based study in the British Columbia, Canada, which also found that MS is a more common underlying cause of death among younger patients. Results showed that a total of 771,288 deaths over a period analyzed. The mean age at death was 74.5 years, with 47.5% being women. MS was mentioned as a cause of death in 2,153 cases, and it was more commonly classified as underlying cause in younger patients than in older ones, accounting for 78% in individuals younger than 40 and 49% in individuals older than 80. When MS was mentioned in the certificates, the data revealed that urinary tract infection was the condition more likely to contribute to death, followed by an aspiration pneumonia, which may occur when bacteria containing pieces of food and drink enter the lungs. Skin disease, respiratory infection, non-infectious respiratory disease, and other infections or sepsis, which is a potentially life-threatening complication or of an infection. The scientists concluded that of the death certificates that mention MS was the underlying cause in 59%, and that the disease is more likely to be the underlying cause in death for patients who were younger at death. Deaths that were due to MS were commonly caused by infections and the conditions that are complications of severe disability. The team also concluded that in the study. They suggest that early treatment aimed at reducing the frequency and severity of these complications would be expected to improve survival in MS. Can you die directly from MS? Yes, if you have damage to the parts of your brain that drive autonomic functions like breathing and heart function, or damage directly to muscles that control organs, etc. However, as the study shows, it is more likely to be from complications from MS. I know this is not a pleasant topic, but of course it's one that we all need to know about. It's very important. Now, next topic. Data from 2 EU trials show the effectiveness of CBD spray in treating spasticity. Data from the 2 trials, a real-life study in Italy and a long-term Czech trial, looked at the impact on cognition, supported the efficacy of a widely approved CBD spray in treating moderate to severe spasticity, muscular stiffness, or involuntary spasms in MS that failed to benefit from other spasticity treatments. Sativix is a formulated extract of the cannabis sativa plant whose principal components are THC and CBD in a 1-to-1 ratio. The medication is approved in about 24 countries, mostly across Europe, but also in Canada, Israel, Australia, and as an add-on treatment to other anti-spasticity medications like baclofen and tazanidine. It is not approved for MS in the U.S. Sativix was superior as an add-on in treating resistant spasticity in MS patients, compared with adjusting first-line spasticity treatment for better efficacy alone. So in the cognition study, that was conducted largely in the Czech Republic, researchers were happy to see that absolutely no negative effect cognitively. So our next topic is rituximab for MS does not increase cancer risk compared to Gilenya and Tysabri, according to the Swedish study. I know this study has been closely watched by many since it's a sister med to Ocrevus. Treatment of MS patients with rituximab does not increase breast cancer risk in women and is not associated with a higher risk for malignant cancer of any type in men or women when compared with Gilenya or with Tysabri, according to this new nationwide study in Sweden. Increased cancer risk is a current long-term concern of using DMTs, disease-modifying therapies, able to exert greater effects on the immune system. This is supported by data from the Oratorio Phase 3 trial in primary progressive MS patients showing that treatment with the DMT Ocrevus was associated with an increased incidence of breast cancer, which continued research was not able to recreate those same increased cancer rates over the general population data. And then the follow-up data that came in just showed that Ocrevus had the same incidence of breast cancer and other cancers as the general population. So they left them to wonder, was this an anomaly from that research? Despite this information, long-term follow-up data, as we said, on cancer risk in large real-world groups of MS patients on novel DMTs are still scarce. Aiming to address this gap, a team from the Karolinska Institute in Sweden assessed breast cancer risk among female MS patients treated with the rituximab. The team also compared the risk to all types of malignant cancer in MS patients treated with different therapies, namely rituximab, Gilenya, and Tysabri. Now, the results revealed one case of malignant breast cancer in women with MS among 2,274 rituximab treatment starts. According to the team, this corresponds to an incident rate of 2.32 cancers per 10,000 per person per year, a measure that the sum actually follows up the duration patient, which is comparable to or possibly lower than the rate of the general female population, 12.07 cancers per 10,000 persons per year. And it's even lower than the rate reported with that ECTRIMS trial. So that is what is actually having them surmise that the follow-up data from that trial was actually correct, and it is in line or lower than the risk with the average population. Now, our next topic is lower mortality rate in the U.S. and Sweden for MS patients treated with rituximab. Treatment of multiple sclerosis patients with the rituximab leads to lower than reported death rates according to a large real-world study in the U.S. and Sweden. The findings also revealed no deaths due to infusion reactions or systemic inflammation. MS brain there for a moment. Recent research from Sweden showed that MS patients receiving rituximab as first-line therapy stay on it longer than other disease-modifying drugs, and they have fewer relapses and less new brain lesions. Also, off-label outside of the approved indications use of rituximab for MS and other disorders is well tolerated, safe, and leads to complete B-cell depletion. Now, our next topic is fingolimod significantly improves quality of life in pediatric MS. Fingolimod is sold under the brand name Gilenya. In the double-blind phase 3 paradigm study trial, the 215 pediatric patients taking the Gilenya for up to 2 years were shown to have reduced annualized relapse rates by 81.9%, reduced annualized rates of new or newly enlarged T2 lesions by 52.6%, and the number of T1 gadolinium enhancing lesions reduced by 66% when compared with patients taking beta interferon. The current study's objective was to compare the quality of life effects of these two medications using the Pediatric Quality of Life Inventory, called the PEDS-QL. Summary statistics of change of baseline PEDS-QL scores as reported by the patients or the parents to scores reported at the end of the trial were pre-planned, and the researchers performed a post-hoc analysis for inferential testing on the between-group differences, the patients and the parent reporting. Study investigators concluded that consistent with primary efficacy results, treatments with fingolimod versus beta interferon was associated with a significant improvement in all measures of health-related quality of life as reported by the patients, and total score and physical health score as reported by their parents. So very good news there. Our next topic, MS relapse rates after DMT initiation, similar between pediatric and adult onset MS. The rate of relapse appears similar between patients with pediatric onset multiple sclerosis and adult onset multiple sclerosis following the initiation of disease-modifying therapies. Yet, disability progression is slower among patients with pediatric onset MS. As MS is now being recognized in toddlers and children at a greater rate, these studies are so important to set a standard of care in pediatric MS. So it was great to hear two major pieces of research, the studies reported at ECTRIMS. Now our next topic is lower relapse risk and disability progression with oral DMT in treatment-naive RRMS patients. In patients with the relapsing remitting MS, the initiation of an oral disease-modifying therapy is associated with a lower relapse risk as well as lower risk for disability progression compared with injectable DMTs normally prescribed to newly diagnosed patients. The Swiss MS treatment registry was used to obtain outcomes data on the patients with MS who were treated with first-line DMT between 1995 and 2017. Now, a total of 2,293 RRMS patients who had never been treated with a DMT were treated with an oral DMT or platform injectable and who had data available at 1 year follow-up were included. The primary outcomes were time to relapse and then 12-month confirmed disability progression. So during mean follow-up of 2.5 years, patients with RRMS who had started an oral disease-modifying therapy were significantly more likely to be relapse-free compared with those receiving the injectables. So big news there. Now, our next topic is patients with multiple sclerosis face greater infection risk. Patients with MS are at an increased risk for any infections, particularly renal tract infections, according to this study presented at ECTRIMS. Patients with MS also have a higher risk for serious hospitalized related infections compared with hospitalized patients without MS. Patients with MS were matched with patients without MS based on age, sex, and record history length. And for the purposes of their analysis, the researchers measured incidence rates and incident race ratios for the first infection by infection type after identifying infections that were recorded after the date of MS diagnosis. During a median follow-up period of 5 years, patients with MS had higher rates of any infection versus patients without MS. Additionally, patients with MS had higher risk of serious hospital-related infections. Females had higher rates of any infection when compared with males in both groups. So compared with patients without MS, patients with MS also had a higher rate of first urinary tract or kidney infections. So very important there, and also relates back to that cause of death study that we were speaking about, with the biggest cause of death being those infections. So if we can find a way to definitely stem off those infections, then let's hope we can bring down those statistics greatly, significantly. So our next topic is sensitivity for predicting a second MS episode increased with the McDonald 2017 criteria. As many of you know, the McDonald criteria for diagnosing MS was revised from the 2010 criteria at last year 2017's ECTRIMS. In this cohort, patients who experienced their first disease event were diagnosed with clinically isolated syndrome were followed to see how the revised McDonald criteria for diagnosing MS performed in clinical practice. The 2017 revised criteria were found to be more sensitive and lead to earlier MS diagnosis and less chance of misdiagnosis as compared to the 2010 criteria. So if you're not familiar with the McDonald criteria for diagnosing MS, you're getting very frustrated because you don't have your final diagnosis, then definitely research McDonald criteria, and you will see exactly what the criteria is to be met, what lengths they go to prevent MS misdiagnosis, and to get that definite diagnosis sooner, which is what is being shown with this research. Okay, our next topic is disease-modifying therapy associated with persistent brain atrophy slowing in MS. In MS patients with multiple sclerosis, brain atrophy appears to continue to slow with each additional year of treatment with disease-modifying therapies, DMTs. According to this new study, a total of 405 patients with relapsing remitting MS who were or were not treated with DMTs based on clinician judgment were enrolled from a single center. Patients underwent annual standardized 3T MRI scans and routine clinical visits between 2005 and 2010. At each magnetic resonance imaging scan time point, the investigators calculated the LC-DMT and also assessed the percentage change in whole brain, gray matter, thalamic, white matter volumes as baseline as it related to the lifetime cumulative DMT. The analysis were adjusted for age, duration of disease, sex, their lesion volumes at baseline, and new T2 lesions that developed over time. Now, our next topic, from sun to salt. This was a big one at ECTRIMS this year. Growing role of environment in MS. A person's genes influence the development of multiple sclerosis, but so does the environment, both that in which an MS patient lives and that which an MS patient creates through diet and other lifestyle choices, the researchers report. The heritability, of course, is in fact a known driver of relative risk in MS, accounting for about 64% of all cases is that genetic factor. Now, in contrast, factors like sunlight and subsequent vitamin D absorption that geography makes available are clear looking at any colored chart of MS cases by country. You can really see the difference. And that closer you get to the equator equation we all talk about. Increasing evidence also suggests that exposure to organic solvents and the inflammation they cause can raise MS risk by 10 times, almost as high as that of being a current smoker, 13 times higher the risk. If you smoke, you have 13 times higher the risk. There's also evidence linking the disease to systemic insults like infection with Epstein-Barr virus, mononucleosis, obesity, obesity in adolescence, and of course the night shift work. There's a host of other things that can make up, of course, our daily life risk. Our genetic structure has not changed, but our environment has changed a lot. Salt, as a dietary additive that now underlies almost everything making up the so-called Western diet, probably is among the most intriguing of this emerging risk factors. Now, smoking and low vitamin D levels are key modifiable factors that show a dramatic interaction with the risk of disability progression. Obesity, vitamin D, and smoking and these other environmental factors are considered emerging risk. That was a huge topic this time. The next topic is early relapses and larger lesions increase the risk of developing secondary progressive MS. A higher frequency of early relapses as well as larger volume of lesions and older age at onset increase the risk of transitioning from lapsing remitting MS to secondary progressive MS, according to the study. This suggests that biological mechanisms occurring early in the disease course. A team from the UK and Italy used MRI methods to analyze the number of cortical and white matter lesions as well as the cortical thinning in 219 of the RRMS patients. White matter is made up of nerve fibers and is the main target for the immune attacks in MS. Of these patients, 116 had one relapse, 53 had two relapses, and 50 had three or more relapses during the first 2 years. These patients were followed for a mean of 7.9 years. Results showed that 59 patients, or 27%, converted to SPMS over a mean period of 6.1 years. At disease onset, a total of 674 in the 166 patients, 76 were found. A higher number of these correlated with a greater risk of SPMS transition. Patients with 7 or more lesions transition to SPMS more quickly than those with fewer lesions. So that's amazing research has come out of ECTRIMS this year, 2018. We will continue this series over the next coming weeks. So please join in the next few weeks so you can get the additional studies and amazing research that was released at ECTRIMS 2018 this year. If you want more information, please visit our website, www.msandmemedia.com. That's msandmemedia.com. I thank you so much for joining me this week for the beginning of our ECTRIMS review, and hope you join me again next week and in the coming weeks as we break down all of the latest news coming out of this research. Thank you and have a wonderful week.